I'm going to speak tonight a bit more on where we are with COVID and specific to concerns and common questions we're receiving about going back to school, to work, and what's going on with the vaccines. I know that everyone's been trying to keep up with all of this and how much our world has changed, and it's my plan this evening to provide you with usable information and to have some time for answering questions that you might have. So I'm going to start by just reminding you of a couple important facts, and forgive me if this is something you've become all too familiar with, but I want to make sure we're all on the same page. The first is to remember that the virus, which is a coronavirus, is called SARS-CoV-2, and the disease it causes is called COVID-19. And people intermix these, and it can be confusing at times, but it actually is relevant. It's especially relevant the more we learn that some people can have the SARS-CoV-2 infection and not develop COVID-19. And the more we've been testing, the more we're identifying people who we either call asymptomatic or call pre-symptomatic, meaning they ultimately get COVID-19, but we're detecting the virus in their bodies before they know it. Remember that we're talking about a coronavirus, and that class of viruses are made of RNA. There are other viruses like hepatitis B that are DNA viruses. And the coronavirus is thought to be the cause of the common cold. So there's many different types of coronaviruses. We also know that some of the coronaviruses can be deadly. The first coronavirus that caused an acute respiratory distress syndrome was named SARS, and it occurred in 2002 or 2003. And that stood for severe acute respiratory syndrome. And then there was a subsequent coronavirus that caused something that was later named Middle East Respiratory Syndrome, or MERS, which occurred in 2012. What we learned about those particular outbreaks has helped us understand this new one, which is the new coronavirus, which causes a similar problem, a severe acute respiratory syndrome. And because this is the second version of that particular syndrome, they're calling it SARS-CoV-2. So now when we refer back to the 2002 coronavirus, we call that SARS-CoV-1. And obviously this has been a big deal. Why wasn't the first SARS and the MERS more significant? Why didn't they cause global pandemic? Well, a couple reasons. One was that they actually were more lethal than the SARS-CoV-2. And when a virus causes a much higher mortality rate, it doesn't have the chance to spread in the population very far. It actually kills too many hosts, and then it doesn't go very far. But the second reason was they were both contained early, and unfortunately this one was not. And remember that when we talk about the disease, we're going to be talking about what it does to you after you've been infected. When we talk about the virus, we may be just talking about detecting the virus. And some people we know now can be infected with the virus but not get the disease. Unfortunately, we don't always know who those people are going to be. So keep all these facts in mind as we go through the rest of the presentation. All right, so what are the current numbers and trends? You've probably seen this on the news on a regular basis. I like to go to the Johns Hopkins Health Security website, where they've been doing cumulative numbers over time. And this map shows you that certainly COVID-19 has affected all the continents except Antarctica, and the relative size of the dots tells you the number of people affected. 27 million and counting around the world, and unfortunately almost a quarter of them have occurred in the United States, with substantial numbers of deaths. In Illinois, the Illinois Department of Public Health is keeping track, and you can see the number of positive cases, which means confirmed test positive. And that's an important piece of information because we don't know, of course, people who we suspect have COVID-19 but don't get tested, or who we have a strong suspicion but they test negative for different reasons. And unfortunately, an unfortunate number of deaths as well. You can see the total number of tests performed, which is over 4,478,000. Now, one of the things that's missing in a lot of the news reports that we don't often hear about is the per capita infection rate. In other words, an adjustment based on the denominator. So for how many people live in a population and how many tests are being done, how positive is the virus, how many of these individuals are being affected. And that's an important piece of information. So it is absolutely true that if you test more, you're going to find more. That doesn't mean you shouldn't test, which has been suggested by some people. What it means is you just have to be thoughtful about how you interpret the numbers. So if you test more and you find more positive cases, you should also want to know, well, in what population is this? In what density of people are we talking about? And that becomes an important information. You can also see that although Illinois was doing pretty well for a while, as we got down in June to some lower numbers, as we've approached September and the fall, we've started to see numbers climbing back up. 7-day moving averages means that instead of just looking day to day, you can follow trends. So the red line is what you want to look at across this graph that goes from left to right. And obviously this is an ongoing concern because we worry that the fall and the winter are going to bring resurgence of COVID-19, unfortunately. And that's because in general, coronaviruses actually thrive in winter. It's also because we're more inside in the winter than we are outside. And it's not unexpected that we're going to see a lot higher numbers coming up, unfortunately. Now, the good news is, and this isn't fully understood yet, the death trend in Illinois and frankly around the US seems to have leveled off or gone down and stayed down. Does this mean that the highest risk individuals already had it early and they're not the ones who are dying now because that already happened? Probably not. It's more likely that what we're seeing is a larger number of individuals who've been infected, and many of them do well in outpatient settings and recover. It also reflects that we've gotten better at diagnosing it early and treating it in different ways. And that may be also why we're seeing this. At the University of Chicago, we've had fewer than 20 people with COVID in the hospital now for over 6 weeks. It's been hovering around that number, and now this week it's been down to about 12. Dramatic difference than when we peaked at about 150 or 160 back in April when I did the first one of these discussions with all of you. So clearly, even though the numbers are going up in the population, the number of people hospitalized and thankfully the number dying seems to have stayed down. Now, whether that's going to continue, we don't know, especially as flu season arrives, and we'll talk more about that. Now, separately, and this is very recent, the American Academy of Pediatrics has published the latest numbers on kids with COVID-19 in the US. You can see it by state there listed, and there's been over 500,000 children diagnosed in the United States. 9 states that are particularly hard hit, and you can see Illinois is one of them at the top there, third, fourth from the top. And one of the important things to keep in mind is what we've said all along, which is that children tend to do okay, much lower hospitalization rates, and thankfully a much lower death rate. But there's a unique situation that's happened with kids that some of you may have heard about. It's called a multisystem inflammatory syndrome. And this was initially thought to be rare, and now it's being described in a number of different situations. They have 186 cases described in 26 states between March and May. And you can see that this is characterized by inflammation in multiple different parts of the body. Why would this be happening in kids and adolescents? Not entirely understood, but perhaps they have a more aggressive immune response to the infection, and that's driving it to affect other organs in the body. Remember that the receptor that enables the virus to go into human cells and cause damage and replicate is present on many organs throughout our body. The reason we see this as primarily a respiratory virus is because of how the virus gets into our body, which is most commonly through our oral mucosa or through our nasal mucosa, in other words, through our mouth and nose. And therefore, more often the virus is getting into our lungs, which is where it does its damage. But if you cough and swallow the virus, it goes into your GI tract. So some people get GI symptoms. And as you can see, looking across some of the numbers and terms on this slide, it can affect all the different organ systems in the body. And we're seeing this in children. Thankfully, this is rare, but it's important, and they've developed some different treatment strategies for these kids when they develop this multi-system inflammatory syndrome. I tell you this not, of course, to scare anyone, but to remind you that although we think kids do well when they get sick with this particular virus, there are two important things to keep in mind. Number one is that some of them do get quite sick. And number two is that children are an incredible vector for carrying the virus and spreading it to other family members or other at-risk individuals. When should you suspect an infection with SARS-CoV-2, and what should you do if you suspect it? Well, first remember, and I showed you a version of this graph in my presentation in April, that there are different stages of the COVID-19. The first one is where somebody actually is exposed to the virus and may even have detectable virus in their nose or in their oral mucosa, but they don't get sick. And when that happens, those individuals may recover completely and we never know about it, or we test them, we find out they're positive, but nothing else happens. But those who get sick are in stage one, the early infection. This is where you feel like you have the flu, fever, dry cough, maybe you have some GI symptoms, a headache, congestion, possibly the loss of sense of smell and taste that's been reported. And then when the body recovers from this, you go back to feeling well. And thankfully, that's what happens to many people who get this infection. Unfortunately, the virus also has the possibility of progressing to an inflammatory phase, where you actually get an overactive inflammatory response, usually in the lungs, but can be in any part of the body. And that overactive inflammatory response is kind of like IBD. In IBD, Crohn's and colitis, is an overactive inflammatory response in the gut. An overactive inflammatory response in your lungs or in your sinuses can result in progression and accumulation of inflammatory proteins. Your entire immune system goes into overdrive, and that's what leads to people ending up in the hospital, sometimes requiring intensive care units and mechanical ventilation, or even dying from this disease. So when we talk about where people are in the COVID-19 spectrum, when they're in the early infection phase, certain treatment strategies might be different than if they're in the hyperinflammatory phase. It's the hyperinflammatory phase where we talk about the treatments we use for IBD potentially squelching the bad outcomes. In other words, some of the treatments that you're all on for your Crohn's and colitis actually might protect you from the worst outcomes in COVID-19. And I'll show you some data to back that up in a minute. You should suspect COVID-19 if you develop any of the symptoms that we've already talked about, but there are some other symptoms to keep in mind as well. In addition to a new loss of taste or smell, which by the way does come back after you recover, you can have nausea, vomiting, or diarrhea. Well, those are challenges to people who have Crohn's and colitis because you might get diarrhea related to your IBD. So distinguishing between what might be COVID-19 and what might be your IBD relapsing is a very important thing to keep in mind. What I can tell you is that those who develop digestive symptoms with COVID-19 also usually have fever and respiratory symptoms to go along with it. It's unlikely that someone would have only digestive symptoms as the sign and symptom of COVID-19. In other words, if you have IBD and you've developed some diarrhea or abdominal cramping that's like your usual IBD, you shouldn't be thinking it's COVID-19 unless you have other problems. And it's important for you to communicate immediately to your medical team. You should also suspect COVID-19 if you've had a known close exposure to someone infected, or if you've had an abnormal chest x-ray, or if you have some abnormal blood tests that we've been looking for. And obviously people who develop persistent and progressive shortness of breath, or pain in the chest, or new confusion, those are all emergency warning signs. You should be going to an emergency department. The CDC has modified some suggestions about when we should get tested, and it's not entirely clear yet exactly what to do. Obviously, if you have symptoms to suspect that you have COVID-19, you should get tested. The one that keeps going back and forth in the recommendations is if you've just had a close contact with someone with confirmed COVID-19. So let's say somebody that you work with has COVID-19 and you've been sitting across from them at work, or maybe in school there's been a case that's positive within your child's classroom. Do you end up getting the kid tested, or do you end up getting tested yourself? Not entirely clear if you're asymptomatic, but it seems reasonable that, of course, if testing was available and easy to get, and in some cases it might be, you might as well get tested. Remember, though, that the test may be falsely negative when you are first infected, primarily because there may not be enough viral particles to trigger the test to be positive. So that's some of the challenges to this, which is if you test immediately after you hear that the person sitting across from you or in the classroom was positive, it might be too soon to know. So you're not off the hook to monitor yourself for 10 to 14 days after an exposure, even if you got tested right away and were negative. That's one of the reasons why people have said, maybe don't test right away, just monitor your fever curve and keep an eye on your symptoms and self-isolate until you are in the clear or until it becomes more obvious. If you've been asked or referred for testing, that's another reason to get tested. So if you do get tested or you suspect you've been exposed and you might be infected, it's really recommended that you isolate yourself. Now, I know this is hard when you live in a home with other people or you have other responsibilities. In fact, even at the University of Chicago, they say that if you worked with a patient who had COVID, but you were wearing your protective equipment and you're asymptomatic and you're wearing a mask, you should still come to work. Back in the beginning of the pandemic, they said if you were exposed in any way, you should stay home for 2 weeks. Well, that's just not practical. And what we found out is it's not necessary. Even if a healthcare worker got sick, if they're wearing their mask, the likelihood they're transmitting it to anyone else is extremely low. They just looked at the numbers at the University of Chicago, and they have no documented cases where one of the healthcare workers developed COVID after getting exposed to someone who had COVID, unless they weren't wearing adequate PPE. And now that we've had, and thankfully the university has done a great job of making sure we all have what we need, that hasn't happened. In fact, the most number of employees who've developed COVID-19 here either were found later that they got it in the community or they got it in the lunchroom. So they've changed all that and how people are working in the office at the hospital here. You also may have heard in the news about the saliva test. So wouldn't it be nice if you had a test you could do yourself, or you could do a test that doesn't require what some of us have called a brain biopsy, where they have to put the swab all the way back in your nose. And in fact, not only did they say the saliva test was as good as, but it might even be better than the nasal swab. So you can see here in these different graphs, the saliva samples are in blue and the nasopharyngeal Q-tip swabs are in green. And in fact, the saliva samples turn positive before the nasopharyngeal swabs do, and they stay positive longer, and they may be a better test. And I'm proud to say that that test was originally designed and developed, as far as I've been told, at the University of Illinois here in our state. So something to be proud of, and this may actually become available as something we could even do at home. Imagine if you can just spit into a little sample cup and have a result quickly. So that's coming. Now, we've also learned about risk factors for outcomes with COVID-19, and I've summarized a lot of data into a single table here. We know that people who are overweight or obese, older than age 65, if they have more than two or more comorbidities, which includes high blood pressure, diabetes, probably chronic lung injury, possibly heart disease, all of these may increase your risk for bad outcomes if you get COVID-19. If you have elevated inflammatory markers, well, that would make sense. But if they're very high, that's a bad sign. And then also related to our patients with IBD, we've seen in every study that's looked at it that if you're on high-dose steroids, when you get infected, you're more likely to have a bad outcome from COVID-19. And the bad outcomes include everything from just being hospitalized to unfortunately needing ICU admission or ventilator use or dying. Now, what has also been seen, and this is the study from the United Kingdom where they randomized people who had COVID and were already in the ICU to low-dose steroids. The reason there's a green arrow in the last row here is because low-dose steroids, when people are in the ICU and needing ventilation, mechanical breathing machines, actually was protective. So when that first came out, people said, well, why is it that high-dose steroids are bad and low-dose steroids are good? Well, high-dose steroids, when you get infected, impairs your body's ability to deal with the infection. Remember the different phases of all this. The low-dose steroids, when you're really sick and when you become mechanically ventilated, appear to help your body deal with that hyperinflation problem, the hyperinflammatory problem. So there are different phases that we're talking about here, and that's the difference. Now let's talk a little bit more about COVID-19 and IBD. Remember that, as I mentioned already, Crohn's disease and ulcerative colitis are conditions where, for reasons we don't fully understand, the gut immune system is overactive. The two main theories are that there's something driving that inflammation, so the bowel thinks that it's protecting you and it's just doing its normal thing, like food poisoning, but it doesn't turn off, or you're missing some regulatory pathway or an off switch. It gets turned on by an infection or something else, and it continues. So when you understand that our primary focus of managing inflammatory bowel disease is to turn down that overactive immune response, it also makes sense why some of those same therapies that we use so effectively to control Crohn's and colitis may also turn down the hyperinflammatory response of COVID-19. There is an international registry that we've contributed to called Secure IBD, and the website's at the bottom there, covidibd.org. It's publicly available. And this is an interactive map that's been created by our friends at the University of Calgary in Canada. And this map is similar to the Johns Hopkins University healthcare map that I showed you earlier, but this is just the cases of confirmed COVID-19 with IBD that have been reported. And we have some of our patients who are in this registry too. And they're looking at all sorts of different factors and what happens to the people. And as you can see, more than 2,200 cases have been reported. There have been 567 of these individuals who required hospitalization, and unfortunately 67 individuals have died. These numbers and this ratio is similar to what's been seen in the general population, the non-IBD population. So keep that in mind. If you want to know a little bit more about that, the website has lots of data. And in fact, the folks who coordinated and created this wonderful database have published the first 500 patients with a statistical analysis. And I'm just going to summarize some key findings for you. The first one is, as I've already mentioned, if you're older, you have a higher risk. Regardless of having IBD, age does matter, as looking at some of the outcomes here. And the columns are the different types of outcomes. You'll see that one of them is the ICU admission or requiring a ventilator or dying. The other outcome in this column is hospitalization or dying, just the two of those combined, and then just looking at death alone. So what I've highlighted here are the statistically significant results. You can see that being on steroids had a 6.8-fold increased risk of this combined endpoint of ICU admission, ventilator use, or death, a 6.5 increased odds of being in the hospital or dying, and an 11-fold increased risk of dying from COVID if you're on high-dose steroids. The other one is comorbidities like high blood pressure, diabetes. You can see that these were significant, especially if you had two or more. And I also want to point out to you, being on a 5-ASA therapy can absolutely increase some risks. Now, why would that be? Because we don't think of your 5-ASA drugs like Asacol, Pentasa, Lialda, Aprizo, sulfasalazine would increase risk. Those are not immune therapies. It doesn't make biological sense. On the other hand, what we've learned is that one of the variables that was reported here that's just reported by the physicians is how active the IBD might have been before this started for the individual patient. And because that's a physician-reported variable and not one that's more objective, we think that many of the patients who are on 5-ASAs may have had more active IBD, which might be a risk factor for bad outcomes, or many places around the world still use these drugs to treat Crohn's, when in fact they have been shown that they don't really affect Crohn's. And in fact, it's thought that maybe those patients also had active Crohn's when this happened. So it doesn't mean that we think these drugs are unsafe, and they're doing some more work to try and figure out why exactly this was statistically significantly associated with some outcomes. The other variable that's on here that's of interest, and it's highlighted in green, is being on an anti-TNF therapy. That's the drugs, infliximab, which you know as Remicade or Renflexis or Inflectra, Humira, Cimzia, or Simponi. And being on an anti-TNF drug in this COVID registry was actually protective against hospitalization or death. And again, it gets back to what we think is that there may be some protection by being on some of these anti-inflammatory therapies. So the main messaging in IBD has been stay on your medicines and stay in remission. Avoid high-dose steroids, but that's not a new message. We've been talking about that in IBD forever. We are recommending to make sure you get vaccinated, and of course, we'll talk a little bit more about vaccines in a few minutes, but influenza is an important one. You don't want to be confused whether you have the flu or whether you have COVID, and it's important to get vaccinated every year regardless. Pneumococcal vaccines, the pneumonia vaccinations, HPV if you're of the right age, men and women, against human papillomavirus, meningitis if you're a college-age student, and shingles is recommended if you're on immune suppressives, and of course anyone over age 50. Keep your appointments with your medical team, monitor your labs, don't skip getting your monitoring tests done just because you're nervous about going to lab. You should still figure out when to go. I usually recommend going first thing in the morning, get your blood drawn. Know if your infusion center has a plan for keeping you safe. I'm happy to say that the University of Chicago's infusion centers do, but so does Metro Infusions, which many of you may go to. We worked with them and they've been wonderful about making sure that you stay safe. But it's appropriate for you to ask. You can call ahead and say, what are you doing to make sure that I'm protected? And then lastly, if your colonoscopy or other procedures have been delayed or canceled, make sure you keep that on your to-do list and it gets rescheduled in an appropriate time. You don't want someone else to forget about it and then you don't get it done. Those are done for important reasons. We're back to doing almost all the same that we were doing before, but everyone gets tested for COVID before they come in. So what do we know works? Well, we've learned a bunch. We, of course, know that hand washing works, and there's been a lot of studies since we were making these general recommendations to confirm that hand washing works and hand sanitizers that contain at least 60% alcohol work. Remember, though, which parts of your hands you don't usually get at so that you wash properly or that you use your Purell in the right places. People often miss the palmar surface here, which is called the thenar eminence around the thumb, in between your fingers, at the tips of your fingers. Make sure you do a good job when you're washing your hands and teach your children to do that well too. Social distancing is not just something that's been recommended because it sounds right. It's actually been studied. And there's a new study that just came out that looked across many different studies across the world and confirmed that in fact, about 6 feet is exactly the right amount to prevent inadvertent transmission from people who may be infected and who may be inadvertently aspirating or spitting out viral particles. This is the study that was just published in The Lancet. This was a meta-analysis of many different studies, and they showed that the further away you are from someone, the less likely you are to actually get infected. And you can see that they recommended a minimum of 1 meter, which is 3 feet. You can understand now why they're suggesting 6 feet is just to make sure you're extra careful. But that's what the data show, and that's one of the reasons why we recommend this. And of course, as we've all heard repeatedly, wearing a mask is not a political statement, it's a medical fact that it prevents you from infecting others and it infects and prevents you from inadvertently becoming infected. One of the things masks do is it prevents you from touching your mouth or your nose, and therefore it prevents you from ending up inadvertently infecting yourself if you've just touched a handle on a door or an elevator button. I know we're all trying to be extra careful about those things, but if you're also wearing a mask, then even if you accidentally have come in contact with viral particles, you're much less likely to touch your face. And so I think that it's important to be doing this properly, to make sure you're wearing them over your nose and mouth, and that you're wearing clean masks and doing your best to adhere to your local rules and regulations about that. There have been a lot of studies now going all the way back to the first SARS and then the MERS, and now, of course, with COVID-19 and SARS-CoV-2, showing that masks actually work. In populations, the population wearing masks reduces the infection risk. The way you get rid of a pandemic is you either vaccinate everybody, you either wait for everyone to get infected and then recover, and those who survive are the ones who are immune and do okay, or you prevent the virus from being able to be spread to other people. So people talk about something called an R naught. It's an actual number that refers to how many people does an individual who's infected have the chance of infecting if we don't take any precautions. And when R naught is greater than 1, that means that for each person infected with the SARS-CoV-2, they can infect more than one other person. So you want R naught to drop below 1, because then naturally the virus is going to just disappear for a while. When R naught is greater than 2 or 3, or in some cases we've now heard that it's as high as 4, that means that we're not taking adequate precautions. If you look at things like there was a motorcycle rally that occurred in South Dakota where most people didn't wear any masks, they saw subsequently a spike in COVID-19 cases in South Dakota. It's very predictable, and it's unfortunate that we continue to see social gatherings where people are not following any of these regulations. It's not just about them. Even if they say, I don't care if I get sick, it's about everyone else that they infect. Well, so what about going back to school and work? Maybe that's the whole reason you came here tonight. So let me try to provide some guidance. The first thing is that we can go from one extreme to the other in understanding what the overall risk might be to individuals. When we have virtual only classes, activities, and events, to as high as something hybrid, like small in-person classes, activities, or groups of students stay together and with the same teacher rather than spreading around into different groups. And students have social distancing when our schools or workplaces, for that matter, have enough room to actually do that, and unfortunately many of them don't. To the opposite end of the spectrum, which is where we're doing everything we used to be doing. I've heard of some different approaches to this by different schools, some that have just decided we're not taking anyone back, we're going to continue to do at-home learning and virtual teaching, to others that have said, you know what, we're going to do half in person and you're only in one classroom with one teacher, and the other half of the day you're at home doing virtual learning. Now, I actually heard this recently and I thought that sounded pretty good, because as soon as there's a positive case in the school, they're already doing virtual learning and they're sort of in the groove of doing that. They can just literally flip a switch and have everyone staying at home when they need to. It's a very challenging problem. And as we've heard repeatedly now, every university that has tried to bring students back, no matter how prepared they thought they were, it's a failed experiment. In other words, you bring the kids back, the students, the young people back, and you test everyone and you think you've got it, everyone's in their own dorms, etc. We know what happens in college and how hard it's going to be to control. And the University of Illinois is no exception. They were really prepared and had a lot of different options. And very quickly, they had to shut down all those classes. So what in the world can we do in these situations? We know people have to get back to work. We know that they're trying their best to provide education to their kids and don't know how long they can keep doing at-home schooling. Let me provide a few resources to help guide you, and we can, of course, answer some questions about this. The CDC website actually has a lot of very helpful tools. I would encourage you to spend a little time there. I've copied a few of them into this presentation. The first one is a back-to-school decision-making tool. This isn't about whether the school tells you to come back, it's whether or not you want to send your kids back. And so you can see the different things on their checklist, from as the top of the list, I feel comfortable with my school's reopening plans for reducing risk of spreading COVID-19, to my child can wear a cloth face covering for an extended period of time if required by the school, and my child has a reliable mode of transportation. You can see all the different facts that have to be considered. And then also you have to look at what's the likelihood you can do at-home learning. It may or may not be possible. So how is this going to affect your child? How is it going to affect you and your ability to support the family? Is it even possible for you to do this, or feasible? Or does the school provide you with instructions and options to do this. So I would encourage you to check out these checklists as one way to help make some decisions. Probably have made the decisions already given the date of this presentation tonight. There's also some other checklists you can look at, which is how to plan for in-person classes. You want to check with your child every morning for any signs or symptoms, including checking their temperature. You should make sure that if they have any signs or symptoms, they stay home. And you should, of course, immediately notify the school so that they can decide what else they need to do. It should also include a school that has the ability to arrange for or direct you to immediate testing. You shouldn't have to go hunting to figure out how to get your child tested if they're sick or if they were in a classroom with someone who was sick. Ideally, the school will have resources to provide to you so that you can get this taken care of. But you should know where you're going to go if that happens and should have that plan. Make sure your child is up to date with recommended vaccines based on their age. And remember that that is recommended, and despite people's concerns, it is still the recommendation for public health. Review and practice, as I've already mentioned, how to properly wash hands, and when we do so, and then make sure that your child knows what to do during the day. If they're feeling uncomfortable with their mask or they start to feel sick, and maybe give them an extra water bottle or something they can keep with them. My wife is a school teacher, and the pictures she shared with me of her going back to classes with some of the kids yesterday, the youngest children, just broke my heart. Seeing them with their masks on and thinking about how this has affected all of us absolutely brought me to tears. And I understand the challenges we're all facing here. The best we can do is keep remembering that we're going to get through this. It's going to end, but we want to keep doing what we can. And that risk is cumulative. Just because you might be taking some risk by having your child go back to school doesn't mean that you give up on all the things that we know works, or that you just throw it all out and say, well, as long as they're going back to school, I might as well let them have play dates again and be around outside without a mask on and around other children. You got to keep vigilant about the things we can control and understand the concept that although there are some risks that we may be taking, you don't want to expose the children to risks otherwise. If you're going back to work, there's some different ways to think about this. The CDC does give you some guidance here, and they break it down into what's your risk of exposure in your job. So, for example, they consider a very high risk for COVID-19 healthcare workers taking care of known or suspected COVID-19 patients. And I'm really proud of how the University of Chicago handled this. And as I already mentioned to you, the extremely low number of healthcare workers who got sick, none of which they immediately traced back to patients unless the healthcare worker wasn't wearing their protective equipment. Lab personnel handling specimens from known or suspected COVID-19 patients, and obviously morgue workers, unfortunately. And then there's some other categories here. Maybe you're in the category of medium or lower risk, and keeping in mind what that means, it's helpful for you to think about how you might approach this. So what do you do at work? Well, hopefully your place of employment has adapted. We recognize that some people work in places where it's been very hard to do anything, but at minimum, you should be able to be wearing a mask. There should be access to hand hygiene, and there should be a way to make sure people who are on the workplace who feel unwell can either be seen by someone who can evaluate them and get tested when it's appropriate, and there should be a communication strategy so everybody who is potentially in contact with someone who becomes unwell or positive can be notified. This is what I've been sending out to patients asking about this. We actually created a dot phrase within our electronic medical record so we can send the same message when it's asked. But the first one is, what are your individual risk factors? Having Crohn's and colitis is not in and of itself a risk for having bad outcomes from COVID-19. It's not. We've looked at it. It's been studied every place where they've looked at it around the world, including Italy, where they had a pandemic surge, and certainly in New York City. Just having IBD wasn't in and of itself a risk, but being older than 65 is a risk. Having comorbidities, as we mentioned, those are risks. So what are your individual risk factors? Secondly, what's the prevalence in your community? So as I'm pointing out to you that the number of positive tests in Illinois is going up, the number of people hospitalized and dying, thankfully, is low and stable. So what's going on in your community, know what your numbers are. Check out your state Department of Health. Look for more local resources to know what the actual numbers are. That might include what's going on in the workplace or what's going on in the school where your children are going. What's the likelihood of your exposure? That goes back to the CDC risk pyramid that I shared with you. And then what precautions are in place? Are you satisfied that you're being protected, your children are being protected? And what exposures may happen when you get back to work? So has there been some adjustment made? Certainly we're now seeing the plexiglass that's been put up at many places where we go to get coffee or other places where we go to have services done. Is there something like that where you work? And if there's not, do you have the resources or do you have the reporting mechanism so you can ask to have that installed? And then also, it's appropriate, completely appropriate, to ask, what is our plan? If my colleague here, Joe, gets sick with COVID and he's across the way from me, are you going to let me know? Are you going to arrange for me to be tested? Are you going to shut down the office for the day to get deep cleaned? What is our plan? And most places have developed one, but if yours hasn't, maybe you can contribute in that way and help them develop one. And then after you've evaluated all these risk factors, I'm here to tell you that our teams at the University of Chicago are available to you. We've been providing letters. We're not asking questions or forcing anybody to go anywhere. We're happy to say that because you have a chronic medical condition, you should work from home. Remember that I'm telling you, having IBD alone is not an increased risk. You're not immune suppressed, and the medicines you're on may be actually helpful in some ways. So we won't ever say no if you want a letter to help you stay home and continue doing what you're doing. But I want to make sure you also understand what we know based on the studies that have been done. All right, so the last part of what I'm going to talk about before we open it up for some Q&A is about the vaccines. Of course, we're all waiting for vaccines. When will they be available and who should get vaccinated? Well, we're talking a lot about this. So we know that patients on some immunosuppressive therapies, and specifically it ends up being azathioprine and 6-MP, if you know those as Imuran or Purinethol, they have a diminished immune response to vaccines. That means when someone gets the vaccination, they don't become immune to the infection. For some of the other therapies, like our biological treatments, we actually don't see that very much. We see a very prompt and appropriate response to vaccines. So that should be reassuring to you. So it's important to understand this piece of information, and also that people who are older are in general at higher risk for infections. So the recommendation in IBD, and this has been described since 2015 and many times since, is that our IBD patients should all be getting vaccinated. This was a recommendation before COVID-19. So that's just general vaccines, like I already mentioned. And I'll share with you a checklist of vaccinations in a minute. The coronavirus, when people get infected, the reason they recover is because their body's immune system does its job, okay? The virus does its damage by entering the body through cells, where it uses the cell's machinery to replicate itself until it kills the cell. And the body's immune system will either attack the virus directly, or the body's immune system may detect the virus within a cell and then attack those cells. So this is a little bit more medical school level education. But the point here for you to understand is that if we're developing vaccines against the coronavirus, the SARS-CoV-2, we can either enhance the way our body can respond to the virus itself, or we can enhance what the virus does to the cells that it infects. So there's different ways to target this, and therefore there are different types of vaccines. So you don't have to know all of this. This is more for people who are really interested in learning more. It's a wonderful paper in one of our high scientific journals called Nature. But one of the vaccines, for example, uses an adenovirus, another virus, to actually carry some component that will develop, that will trigger an immune response in your body and protect you against the coronavirus infection. So if your body's immune system sees a piece of the coronavirus, but not the actual coronavirus, and develops antibodies against that piece, then when you get exposed to the actual coronavirus, your body's immune system will attack it and prevent it from causing any problems. There are other types of vaccines, some of which are protein-based or nucleic acid-based, or even viral vector vaccines, different types of vaccines. The viral vector vaccine, by the way, is the one that AstraZeneca was developing with Oxford, and it's the one that was halted. It was announced today, and I'll tell you a little bit more about that. In order for vaccines or any new therapy to make it to market, there are different phases. You may have heard of like a phase 1 or phase 2, where people are saying vaccines are in phase 3 trials. Well, I wanted to share with you what the phases are. Phase 1 is all about safety and sort of pharmacokinetics. What happens in the body? How does the drug or device or virus get cleared or vaccine get cleared from the body? Phase 2 is looking at dose ranging. How much do you need to cause an effect? What's the least amount that you need to have the desired effect, and some additional safety. Phase 3, though, is the pre-approval phase. Phase 3 is when there's large studies, usually randomized to a group that gets placebo or standard of care, and another group that gets the new intervention. So in the vaccine trials, phase 3 is that a group of people are getting a placebo vaccine and another group are getting the coronavirus or the SARS-CoV-2 vaccine. And phase 3 is necessary by the FDA to lead to regulatory approval so something can come to market or be used in humans. And they collect safety, of course, in phase 3. Phase 4 happens after the product is on the market and being used. That's post-marketing. And this is almost always required by the FDA to continue looking at safety. And I guarantee you that the vaccine trials will include that. So this is just to remind you what the different phases are. So if you hear that something's in phase 3, that's one step away from being approved. But phase 3 are the hardest trials to do because they're the biggest trials. So one phase 3 trial for the vaccine, for example, has 30,000 patients that are being recruited. On the other hand, since everybody wants to be in these trials or is very interested in getting the vaccines approved, they haven't had so much trouble recruiting people. The challenge, though, in terms of statistical significance, is you have to have enough people who develop COVID-19 on placebo and enough that don't develop it with the vaccine to prove that the vaccine is doing its job. If you study it in a population where there's practically no COVID-19 anymore, you're going to need a lot more people followed for a lot longer time before you have enough of the signal in the placebo arm to show a difference than those who got vaccinated. So hopefully you're following me on this. Here's the update. If you look across the top there, the nice colored graphic is the number of vaccines that are in the different phases. So there's 24 vaccines that are in phase 1, 14 that have made it to phase 2, 9 that are currently in phase 3, and that there are a few that have been received early approval for limited use. And these are in different countries. You can see Russia and China have a couple different ones that are being used. And the CDC has actually informed state health officials to develop a distribution plan. And they've said that it might be as soon as November. Most of us think that that's optimistic and that it's unlikely, even in the highest risk groups, like the healthcare workers on the front lines and the military, it may not happen that early. Pfizer was saying they might know if their vaccine works as early as October. That doesn't mean they're done with phase 3 trials. And AstraZeneca, as I already mentioned to you, had to hold their trial because they had one serious adverse reaction. I've heard variously what it is. I don't know if this is confirmed yet, but I was told that it was transverse myelitis, which is an inflammatory condition of the spinal cord. And it wasn't clear if this was somebody who got the vaccine or who got placebo, which may or may not have been an active part of the vaccine, or what it was. It was not a COVID. You won't get COVID-19 from these vaccines. None of them use active virus as part of the way they do this. So here are the vaccines to watch. You can see how they're, what type of vaccine they are. They're all injections. This is primarily because they're proteins, just like why our biological therapies for IBD are injections or infusions. And you can see the number of doses and timing. Some of them require 2, some of them are 1. They're different structures and strategies. So one of these has got to hit, maybe more than one will, and then we'll learn more, and hopefully we'll start providing them. Who are going to get them? Well, go back to that CDC website again, and you can see that they say, depending on how bad the pandemic is, whether it's low severity pandemic or high or very high severity pandemic, there are different groups that should be vaccinated. And you can see that they consider at the very top here, deployed and mission essential personnel in the military. They'll get vaccinated regardless. You can see that in the healthcare world, which is where I live, of course, and many of you may be working, all different severities of the pandemic tell us to get vaccinated. Where are people who have IBD? Well, in theory, they might be considered down here as adults with high-risk conditions. And you can see that there's some different strategies of what tiers they should be in. And you can also see that children are in different tiers. So if this was really controlled in how they roll out the vaccines, the IBD population may not even be in the first line to get the vaccine. And I'm here to tell you and remind you that that might be okay if we're getting other people vaccinated and we're trying to shut down the pandemic in other ways. That doesn't mean that we're not going to try to vaccinate everybody. It just means there's going to be some priorities set. The other way that the committee that looks at immunization recommendations has broken it down into what they call critical healthcare workers and others, other healthcare and essential workers and high-risk individuals, and the general population. Technically, IBD might be considered high risk, but the reality is that most of you aren't, and that's good news, and you should keep that in mind. Here's who they really say are high risk. Immune deficiencies, that's not IBD, it's an immune overactivity. Immune deficiencies are people who have congenital immune deficiencies. High-dose steroids is listed on the list here. And then they say use of other immune weakening medicines. This is how IBD will be considered high risk, even though we're thinking that for COVID-19, it may not actually be something that's making you higher risk. So that's where we'll talk about the IBD population. This is another plug for me to remind you that you should get your flu shot. They're available now. You can go to Walgreens or CVS, and we have them in clinics. So if you ask us, we're happy to set that up. You can come in. If you go to our River East Clinic or Orland Park, it can be a quick, easy stop. If you come down to Hyde Park, we just need to prepare for you to come and make sure we have it on our list and that you can get it done. So I'll end with why you should see us by telehealth or when you should be seen in person. As much as we're happy to be doing telehealth and do video visits, and I did 15 of them today, the reality is that I fear that we're going to end up missing some important things. So I created a list of when it should be done in person. If you're a new patient with a new diagnosis, there's no substitute for a careful exam, having somebody look at your bottom, examine your joints, feel your belly. If you don't have the technology, you should be seen in person. It's not an excuse to not be seen at all. If you have sensitive matters, and I brought this up a lot, maybe you're in a home where the only computer's in the kitchen and there's somebody else there that you don't want them to hear what you're talking about or you don't feel safe. That would be a good reason to request an in-person visit. If you have new symptoms that we might require an exam, and I keep telling my fellows and trainees the importance of taking a look at people's bottoms to know what's going on, distinguishing between Crohn's and ulcerative colitis, make sure what someone else was told was a hemorrhoid wasn't actually Crohn's disease, etc. And even if we continue with the video visits, which I'm hoping we will, and I actually enjoy them, and I love seeing you all in your homes, I still think that once a year you should be seen in person. And we can alternate that with telehealth visits. That's my suggestion. But I do think that we shouldn't get away from completely having the opportunity to examine people and to make sure that we do some things in person. It's also a lot easier to get your blood drawn when we see you in person, etc. Okay, so what if you test positive? You know this already. You should stay home, let your doctor know or your nurses, separate yourself from others, and get rest and stay hydrated and monitor your symptoms. If you start to become short of breath, you need to go to the emergency department, and you should obviously page us and let us know what's going on. Fortunately, I'll tell you that we've had some people in our practice who had COVID-19. Thankfully, only one was hospitalized, and he ended up not having COVID-19. We thought he did, but he didn't. So we're very thankful for the outcomes we've seen with our patients, and we want to make sure you all stay healthy and safe. So resources for you. So you're probably thinking, gosh, I'm glad I'm going to get all these slides because I need to have this all written down. True. I'll also tell you, you can go to this nonprofit that I'm part of called Cornerstones Health. We have checklists, not just for vaccines, but includes checklists for monitoring your therapies, depending on which drugs you're on, tells you what blood tests you might want to get and how to get them, what cancer prevention you should be doing, what you should do to keep your bones healthy, and some other general recommendations. And we even have them in other languages. So cornerstoneshealth.org. And then we've presented this before, and you'll get these slides, so you'll have it. But if you need help getting your medicines because your insurance has changed, because your employment has changed, because your financial situation is difficult, there are all these different resources available to get your therapies, whether they're the advanced therapies, the more conventional therapies, and there's a variety of different places you can call or go on websites and get your medicines, and our teams are prepared to help you as well with samples or with coupons or with other strategies. We've got lots of tricks. Please don't go without telling us. If you have a stoma, an ostomy, the United Ostomy Association of America has a variety of resources to get you free supplies if you need them, and this is also included in our resources list. So I want to thank you for joining us. Thank you, everybody. Take care.